Hey everyone, welcome back to the Real Women's Health Podcast. I'm Dr. Kristin Rojas, a board certified gynecologic surgeon and fellowship trained breast cancer surgeon. And today I'm very excited to have my good friend and colleague, Dr. Denny Goulet, on the show. Denny, welcome to the show.
Thank you so much for having me, Kristin. Pleasure to be here.
I am thrilled that you're here all the way from Washington State. Hopefully at some point you and Delaney and Stella will come visit us in Miami and maybe we can do a follow-up to this in person. But
I think that sounds wonderful. Absolutely, some beach time.
Yeah, exactly. Everyone needs it. You're probably vitamin D deficient, so it's time.
Yeah, definitely.
So Dr. Goulet is a board certified OBGYN. He went to undergrad at Boston College, got an MPH in health policy at Dartmouth. He went to medical school at the University of Washington, and then he joined me at the best residency program in the world, Brown University Women and Infants Hospital, where we were co-residents for 4 years. Currently, Dr. Goulet is an OBGYN at the Everett Clinic in Everett, Washington, which is just north of Seattle. He provides full spectrum obstetrics and gynecology care, including low and high risk obstetrics, delivering babies, all the way to GYN surgery, which is what we're going to talk about today, including minimally invasive surgery, including both laparoscopic and robotic surgery. So in addition to his clinical practice, he's also a clinical assistant professor at the Elson S. Floyd School of Medicine at Washington State University, helping to teach the next generation of Washington State's physicians. So, yay, I'm so glad you're here.
I'm so happy to be here. This is wonderful. I'm glad you do this.
Perfect. So, Denny, as you may know, this focus of this podcast is to teach women who aren't in medicine about all the different roles that OBGYNs can have and like when you see certain types of gynecologists or obstetricians. And so I want you to tell us a little bit about the patients you see. But first, why don't you tell us why you got into OBGYN?
Well, it's funny. I did not expect to go into OBGYN at all when I went into medical school. And, you know, I was first exposed to it really widely during our third year when we rotated with some fantastic OBGYNs kind of in the central part of Washington State. And I saw this incredible relationship that they developed with their patients throughout pregnancies and over a lifetime, and got to be a part of this really, really special time in people's lives, building their families, as well as, you know, taking them through difficult times and providing, you know, really advanced and specialized surgery for folks that can be really life-changing. And so you put all those things together, and there's just nothing like OBGYN. I loved it, and nothing else could hold a candle.
Yeah, I agree. One of the reasons that I was drawn to breast cancer care is for the same kind of continuity. You are the patient surgeon, and then you end up meeting them and their families, and they're going through a challenging time in their lives, but then you also get to continue to see them and get to know them really well. And so I totally get that.
Yeah, and it's one of the things that I love about my job now is because I get to do all those things. I get to see folks who are just newly pregnant. We do the first ultrasound in the office, and you kind of get that awe-inspiring moment when you first see that little kind of flicker of a heartbeat, all the way through, you know, doing deliveries and C-sections, as well as, you know, seeing folks who really maybe feel like they've tried everything and maybe no one will listen to them, and they're having, you know, horrible issues with, you know, really, really painful or heavy periods, and you can provide, you know, really life-changing treatment, whether that's medicine or surgery, that can have a huge impact on their lives.
Yeah, I think that one of the important points I want to convey to all the listeners is that gynecologists actually do quite a bit of surgery, like big surgeries. And so why don't you, and what I did want to focus on today is hysterectomy. Like, what is a hysterectomy, and why would a patient maybe want a hysterectomy?
Yeah, sure. So I think there's a lot of, you know, my wife and I always talk about how important language is and how important words are. And we oftentimes in medicine use different words and kind of get thrown around in kind of public conversations. So when we as gynecologists think of a total hysterectomy, what that means to me as a surgeon is that means removing the uterus and the cervix. It doesn't have anything to do with the ovaries. And so if someone has, in our world, has had a total hysterectomy, it means that the uterus or the womb is removed along with the cervix, but the ovaries are still there. They're still producing estrogen, progesterone, they're still producing all the normal hormones. So people do not go through menopause with that. A partial hysterectomy, I would say, is kind of a more rare entity these days, where someone maybe has the uterus removed, but the cervix left inside, as well as the ovaries left inside. There are certainly indications for that, but it's pretty rare. And then having a total hysterectomy along with oophorectomy, which is a ridiculous medical word that no one can say or spell, means removing the ovaries as well. And we do that from time to time, but it's also pretty rare.
Yeah, I would like to just go ahead and make a plug to say that we completely abolished the word partial hysterectomy because it's very confusing. Patients come in and it means different things to different patients. So for our listeners, if they've listened to my episode with Dr. Jenna Emerson about HPV and cervical cancer, we talked about what actually the cervix is. And the way I describe it to patients is if the uterus is an upside down wine bottle, then the cervix is the cork. And so I like wine analogies, analogies for everything. And so the cervix is actually the bottom part of the uterus that connects the vagina and the uterus. And so we typically always remove the cervix with the uterus when we're doing hysterectomy, and that makes it total. But what do you call it when you remove the fallopian tube?
So there's another medical word that is hard to say and spell, but it's called a salpingectomy. And so if you remove the fallopian tubes along with removing the uterus and the cervix, we have some really, really great data that came out several years ago that actually reduces the risk of ovarian cancer for folks in the future without having any effect on hormones. So it's a really, really nice and very easy and simple thing to do at the time of surgery that can provide kind of long-lasting health benefits without much in the way of risks or complications.
Yeah, the fallopian tubes are already attached to the uterus, so might as well just take it all out together. And the reason that we say it decreases ovarian cancer risk is because one of two reasons. Either ovarian cancer may come from the fallopian tubes, or that they're all kind of part of the same disease entity that is decreased when you remove the tubes. So if you have a patient who has their uterus removed, their 2 fallopian tubes, and their 2 ovaries, what do you call that?
So they've had a total hysterectomy, bilateral, meaning both sides, salpingectomy, and oophorectomy. Which, certainly there's an indication to do that for folks who have cancer or maybe have a history of, significant ovarian cysts that are concerning or kind of, we call this borderline characteristic. So potentially could transition into a more aggressive form of cancer. So it's something we do. And we have to have, pretty significant discussions about it because it can have significant health implications moving forward. Increasing heart disease risk and osteoporosis, things like that. So weak bones. But, for some people, it is the right call. And so that's why I love my job so much, because we get to have these conversations and figure out kind of what fits for every person.
Yeah. And I just also want to echo what you said before that was right, is that, women don't go through menopause if you remove just the uterus, although their periods stop. Menopause is actually when the ovaries stop working or the ovaries are removed. And so even though we remove the uterus, it doesn't necessarily mean that a woman is menopausal because she still has her ovaries. So ovaries do a lot of good things, including making estrogen, and which is good for your bones, your brain, your heart, etc. And so there's been a big push now to leave ovaries in place if we can, if there's no other reason to remove them, because that helps decrease the risk of osteoporosis.
Yeah, absolutely.
So what are some typical reasons that patients would come to you for a hysterectomy?
I think probably the number one reason that I see folks and that we, decide on surgery as the right next step is probably heavy bleeding. Folks that have tried different hormonal pills or non-hormonal pills to slow or decrease their bleeding. They've tried things like IUDs, which can be a fantastic option for some folks. IUDs, a lot of people are not aware that one of the IUDs in particular that has a progesterone in it is actually FDA approved both to prevent pregnancy as well as to decrease heavy bleeding. And it's a simple office procedure, and it decreases bleeding to a point that people are satisfied like 80% of the time. So it's a really, really significant benefit, but 80% is not 100. And so there are certainly folks that try these different things and they've kind of exhausted all their options, and they say, look, we got to do something else because I can't go on dealing with all these symptoms. So that's probably the number one thing. Some folks have big fibroids, which are a benign tumor. It's kind of this growth that is super common in the uterus, and they can provide lots of pelvic symptoms like bulk and difficulty, emptying your bladder or moving your bowels. That's another big reason to do a hysterectomy. Pain, to some extent, can also kind of overlie with some of these things, but pain's complicated. And I'm the first to admit to folks that pain is one of the things in medicine we wish we knew more about and we wish we understood better. Surgery is not always the right option for pain, but sometimes there can be kind of a little overlay as far as symptoms go with some of the other issues that happen in the pelvis.
Yeah, I think that's a really good point, is that because, pelvic pain is really common, and sometimes surgery can even make the situation worse depending on why you're having the pain.
Yeah, absolutely. And that's a really, really important point that, pain is so complex that, anytime we do surgery, we're cutting on things. And one of the things that's disrupted is nerves, and nerves, send pain signals to the brain. And so, it's hard to stomach that, but it's true that sometimes we do things that actually, cause people pain that can be long lasting.
So who would you say is not a good candidate for a hysterectomy? Like, what are the most common, what's like a clinical picture of someone you would say, okay, this is not the right choice, or we should do this first?
I think folks who maybe are really frustrated with the symptoms they're having, but they haven't tried something else first. I think that's probably the number one thing, where you've got somebody who's sick and tired of having the periods they're having, and they know they're not going to have any more children, or they're not going to have any children, period. And they say, just take it out, doc. Just, I don't need it. Just take it out. And I totally understand that sentiment, but surgery, you and I both do surgery. I think we like that part of our jobs, but you want to make sure you're doing the right surgery for the right person. And sometimes that means making sure that you can't solve their problems with something simpler and that has less risk. So something like a medicine or an IUD or something like that can be really helpful, can turn people's lives around, and spare them the risk of going under general anesthesia and the recovery time and things like that. And even though, we can, laparoscopic surgery is way better from a recovery standpoint than open surgery, or kind of the bigger incisions that we used to make more often. But even still, there's risks, and there's recovery and time out of work and stuff like that.
I feel like IUDs get a really bad rap, and they can be really, really helpful, not only from, like you said, a contraceptive standpoint. So they are really effective at preventing unwanted pregnancies, like as effective as having your tubes tied, but they make the lining of the endometrium, the lining of the uterus, which is called the endometrium, really, really thin. And so most women stop having periods. And it's not because you're like not bleeding and the endometrium is like building up somewhere else, because that's what I feel like some patients have asked me that, and which is like a logical assumption, but it actually just makes the endometrium so thin that you don't need to have a period, because you actually physiologically, newsflash, don't need to have a period.
Yeah, I wish that we could like put billboards up that say, it's not necessary, it's okay. And I talk to patients about that too. If you're not having a period because of other health issues or stuff like that, sometimes there are real world things that we need to address or treat, because that could be dangerous. But if you're not having a period because we're giving you something to stop it, it's totally safe. And you could go years without a period and it's like not a problem at all.
Yeah, I agree. So you talked a little bit about laparoscopic hysterectomy. So tell us, what do you mean when you say minimally invasive, and what kind of options do you have for patients who are interested in those options?
Yeah, so one of the kind of original forms of minimally invasive surgery is what we call a vaginal hysterectomy, where there are no incisions in the belly, and we actually remove the uterus and the cervix through the vagina. And that is a great option for some folks. It's not right for everybody, and certain folks who have really large uterus, or they have kind of a lot of pain that goes along with it, or a history of endometriosis, or they've had surgeries in their belly, like they've had their appendix removed, or they've had a C-section or something like that. That's a little bit less safe. And so then we move to something like a laparoscopic surgery. And laparoscopic and robotic surgery, there's a lot of overlap, and there's a lot of kind of people hear about those things maybe kind of in passing. But they're really, really cool technology that allows us to make little incisions. They're about the width of like, your finger or like a pen. And between 3 and 5 incisions on your belly. Usually one of them is kind of hidden in the belly button, and then the other ones are kind of on the sides of your belly. And we can do all this surgery with kind of fiber optic screens and cameras and these long instruments that fit through those little incisions. And we can basically accomplish the same thing that used to require a big C-section type incision, or even a big up and down incision on your belly. And that has huge implications for patients. I mean, it's so fantastic to see my patients even later in the day. I've got folks that are able to go home the same day after having a hysterectomy that, in a previous generation, they might stay in the hospital for like 4 or 5 days. And it's so great to see how pleased they are with how well they feel, and the impact that surgery has on their life with relatively, minimal downtime, which is awesome.
Yeah, I think being able to go home on the same day of surgery safely is also huge in the setting of the pandemic, right?
Absolutely. And, the way I don't want folks to get kind of too tied up on, whether it's the same day or the next day, because it comes out to kind of the number of hours that you are after surgery. So you have surgery in the afternoon, certainly you might need to spend the night and, go home in the morning. But, if you have surgery done in the morning and you're out of the OR by, let's say, 9:30, something like that, by, late afternoon or dinner time, most folks are feeling well enough to, go home. They're taking some oral pain medicine. Most of the pain is controlled with just Tylenol and ibuprofen, with just very minimal, narcotic use, which is another big, the previous pandemic that we were fighting was, the issue with opiates. And I know that's a big issue in your world. And you've done like awesome research. I like tell all my friends about like this cool Dr. Rojas, who has done all this cool publications and research. But we can limit that use of those really dangerous and potentially addictive meds with the different type of surgery that we choose. And that's pretty huge.
Yeah, Dr. Goulet, flattery will get you everywhere, and a favorable podcast video.
We know each other quite well, and I am aware of that.
Okay, question. What's the deal with a robotic hysterectomy? How is robotic different from regular laparoscopy? Like, what happens in the OR, and tell patients about what's special about the robot.
We were talking about words that are confusing, and like partial hysterectomy is confusing. Robotic surgery is really confusing too, because it sounds like some like robot's going to like walk in and do your surgery on its own, which is not at all the case. But it's basically a very advanced computer system that coordinates with this kind of surgeon-controlled console. So it's not like, I'm across town or something like that. Still in the room doing surgery. but it allows you to use even more advanced kind of visualization. So it actually is a 3D video. So you can have depth perception, kind of like watching a 3D IMAX, basically. In addition to instruments that have multiple different kind of motions that you can make them do. And in addition to that, you can eliminate like fine motor tremors and things like that. So all of us, even the most like, still-handed person in the world has, maybe a little bit of a motion in their hand or something like that when they're pointing at something. And because these computer systems are so advanced, they can actually take that out and make completely smooth everything. They can use, make the instruments, instead of kind of just, of course, I'm going to look like a robot here, but instead of just opening your hands this way, they can introduce kind of a wristed motion, which is really cool. And just little things like that can make you so much more effective as a surgeon and make it more beneficial for the patient.
Yeah, you actually just reminded me of when I told Jorge, I tried to explain what a robotic surgery was and what happens, and he Googled it, and there's like a video of the robot like peeling a grape.
Yeah.
So he always refers to robotic surgery as peeling the grapes now.
It's like grape surgery.
Yeah, yeah, exactly. So the patient goes to the operating room, they go to sleep. They're put to sleep with anesthesia, and then you move the big like, I don't say robot, but it doesn't really look like a robot, like you said.
We call it a robot, but it is. It's this large kind of instrument holding device that moves the instruments in concert with, or because I'm moving kind of these hand pieces, basically. So the robot does exactly what I tell it to do.
Yeah, so they come in with the arms around, and you put the trocars and the arms in the belly, and then you're in the room, like you said, but you're not actually scrubbed. You're sitting at like basically a video game console, and you have your hands in the thing, and you're going like this, and it's changing the motions of the arms inside the robot.
Exactly. Yep. And you have another either assistant or another physician with you at the bedside that can kind of hand you things or move things in and out through another instrument site. And the great thing about robotic surgery is that it allows us to do more surgeries through that minimally invasive means. So through those small little incisions than we would otherwise. So folks who have had multiple previous surgeries or have really large, fibroids and uteruses, or have really, really advanced endometriosis, whereas, maybe 20 years ago, all of those surgeries would have been done through big incisions, multiple days in the hospital. We can still use those small incisions, get them out the same day or the next day, decrease the amount of time that they spend taking pain medicine, decrease their risk of infections and of having issues with their incisions, and kind of get them back to their life that much faster.
Yeah, and so you still take the uterus out through the vagina though, right? Like you keep these tiny little holes, you basically release the uterus from all of its attachments, and then it comes through the vagina.
Yep.
Is that
exactly.
right?
Yep.
Yeah. So what kind of complications do you warn patients about with the hysterectomy? Like, what do you want them to watch out for if they or a loved one has a hysterectomy?
Yeah. So, the biggest risks anytime we do surgery, there's a risk of bleeding because we're, making incisions and we're operating around blood vessels. There's a risk of an infection we talked about. And fortunately, those risks are decreased when you are able to use these smaller incisions or, minimally invasive surgery. And so we want people to look out for feeling generally unwell. Are they having a fever? Do they feel lethargic? Are they developing nausea, vomiting, things like that? Are they feeling lightheaded or dizzy and having difficult time standing up? And then we want them to keep an eye on kind of how their incisions are looking. Is there redness, things like that? There's also the risk anytime we're operating, inside the abdomen, of damage to other, organs in the area. Your intestines are in there, your bladder is, down in the pelvis. And so, we certainly want to make sure that folks are emptying their bladder normally, that they're not having blood in their urine, stuff like that. And a little bit of that, sometimes you will have a little irritation because during surgery, you have to have a catheter, a tube that goes into your bladder and drains your bladder to keep it empty during surgery. And that can be a little irritating. It's one of the things that patients tell me the most is that just that sensation of having a bladder or having, a tube in their bladder, waking up with that is like one of the biggest points of discomfort. And once we're able to get that out, once we're able to get them kind of peeing on their own, oftentimes folks feel better. But, we think about all the different things that we've done to a patient while they're in the operating room, and what the potential issues that could come up because of those things.
Yeah, so pain not controlled with oral medications, fever, not going to the bathroom normally, maybe like back pain, and then fainting or feeling weak and just not feeling well. Let's say summarize it.
Yeah, absolutely. Yeah. And the risks of those things, the risk of some sort of complication after major surgery like hysterectomy, typically, in the single digits. You're talking about, maybe a 1 to 5% risk of those things. It depends on a little bit on the population, and depends a little bit on the indication why you're doing the surgery. So it's a relatively small number, but it's not zero. And so we certainly want to have a good, close, relationship, communication with the patients to make sure that they report anything that seems a little off, and we can, follow up if we need to.
Yeah. So I think those are all my questions about hysterectomies. Is there any other thing that you can think of that patients may want to know about? What common questions they ask you, or
one of the other. Yeah, go ahead.
I was going to say, maybe you can clarify for patients when they still need a pap smear and when they don't, because that might be confusing for some. And then
Absolutely.
Also say whatever you were going to say.
Yeah, that's definitely a big thing. So if we do what's called a total hysterectomy, remove the uterus and the cervix, what we do during a pap smear is test the cells on the cervix. So if you don't have a cervix anymore and you've never had major issues with your pap smear, meaning you've never had cervical cancer, you've never had a procedure to remove part of the cervix, like a LEEP procedure or a cone biopsy, you've never had what's called high-grade cervical dysplasia or high-grade abnormalities, you never have to have a pap smear the rest of your life. Some folks, it's not the reason to do a hysterectomy, but it's a nice little kind of side benefit. The other thing that comes up a lot is people ask about, what will sex be like after hysterectomy? And, it's a really important thing, because obviously intimacy and sex are important issues in people's lives. And, people kind of think about, well, if the cervix is removed, is that going to like change the way sex feels or change, enjoyment with sex, those sorts of things. And fortunately, we have actually pretty good data that shows that that's not the case. That if we remove the uterus and the cervix, the sutures that get placed at the top of the vagina, the vagina kind of maintains its normal size, normal length, all that kind of stuff. And that long term, like after you make it through that initial healing phase, there's no big impacts on sex. We're not removing the ovaries most of the time, like we mentioned. And so your body still has the normal amounts of estrogen. So those tissues are still kind of just the same way they were before the hysterectomy. And it doesn't really have an impact on lubrication or things like that. So, folks have typically a pretty normal sex life after hysterectomy.
Yeah, you would say the thing we tell patients, though, is to wait until you see that doctor and get clearance from your doctor before you start having sex again after hysterectomy, right?
100%, absolutely. And that's probably we talked a little bit about complications. One of the big things that we think about is, making sure that all the incisions heal. And the incisions you see on your belly, you can see those relatively easily. But there is an incision at the top of the vagina that has to heal up really well before you have anything inside the vagina, including sex. And typically that time frame is somewhere in the 6 to 8 week mark, but it's really important that you talk with your doc to make sure that, everything's looking normal.
Okay, that's perfect. I think that is really helpful information for everyone who's thinking of having a hysterectomy. I feel like everyone's mom has had a hysterectomy. Like, I feel like they were just taking uteruses out left and right in the day. Don't you think so too?
100%. Yeah. And it's understandable maybe in some ways because they just maybe didn't have as many different options as we have now, with things like IUDs that can be so incredibly helpful for so many of the symptoms that we used to do hysterectomies for. But it's great to know, I think it's great for people to know that it is still an option, and it's still something that we as gynecologists can provide a great service for folks, and can really make an impact on their lives.
That's exactly right. Okay, so I think that's all that we're going to learn about hysterectomies today, especially minimally invasive hysterectomies. So if you are in the Pacific Northwest and you want to see an excellent minimally invasive gynecologist, you can go see Dr. Denny Goulet. I have personally witnessed his surgical skills, and he gets my stamp of approval. So everyone can go check him out. And also, I remember. So everyone that's been on my podcast, Lena, Jenna, Mina, Denny, you are Denny, Desmond, has to tell me one of their favorite memories from residency, and I have to obviously be involved. So what's yours?
Well, I don't know how you could possibly not be in my favorite memories from residency, Kristin. We had a ton of fun. I mean, we worked really, really hard in residency, long hours, and definitely some, emotional times. But we did have some fun too. And we had the great opportunity for one of your birthdays to celebrate on a sailboat. Your wonderful husband, Jorge, who's like, he's like my spirit animal. He has my dream job, I think, as a sailboat captain, arranged for us to go out on a sailboat and watch part of the America's Cup from the water, and celebrate Dr. Kristin Rojas' birthday with a cake and the whole 9 yards, out in the Newport, Rhode Island area. It was a total blast.
That was a really fun day. Yeah, I agree. I thought you were going to talk about my 30th birthday when we did the all white party at the top. That
was another epic birthday, but it will keep a little bit of mystery for your podcast listeners and viewers about that one. But that was also just epic.
I actually saw those pictures the other day, and I had worn a white wig, and you also had the white wig on at some point. I was going to send you that.
Some of us have less hair. We're more appropriate to be wearing wigs these days.
Okay, that I'd forgotten about. Yeah, I'd forgotten about the boat birthday. That's great. Okay, well, thank you so much for joining me, Dr. Goulet. I am so happy to see you. I feel like I obviously don't ever get to talk to you anymore, and hopefully I can get your brilliant and wonderful wife, Dr. Delaney, on this podcast to talk about another women's health topic in the near future. And hopefully you come visit us soon.
Sounds great. This was an absolute blast. We'll definitely make sure that Delaney gets on, and miss you guys, and can't wait to see you in real life soon.
Yes, thank you so much, Denny. Bye, everyone. Take care. Stay safe.
Bye-bye.